My name is Li Meng. I'm an associate professor of anesthesiology, University of Pittsburgh School of Medicine. Today, I'm going to review complications, including etiology, prevention, and treatment of basic topics in anesthesiology. The first part is about trauma. Acute and chronic injury from laryngoscopy and trachea intubation include, but not limited to, bloody nose and trauma to the nasal passages from nasal intubation, laryngeal and tracheal edema and scarring, dislocation of the adenoid cartilage, ductal retention cyst, subglottic and posterior glottic stenosis, trachea ulceration and stricture, and esophageal intubation. Trauma of nasal intubation can cause short-term and long-term injuries. Trauma to the larynx more frequently following blind nasal intubation than direct vision. Removing adenoid tissue and then blocking the airway following blind nasal intubation happens in children. Laceration of posterior pharyngeal mucosa reported in 3% of nasal intubation. The etiology of intubation trauma include difficult and repeated attempts or traumatic at a tracheal intubation, endotracheal tube movement, large size and high pressure cuff of endotracheal tube, long duration of intubation, bacterial superinfection, GI reflux with a spillover of the acid into the laryngeal and subglottic region, acute or chronic disease states with altered consciousness, poor tissue perfusion, or hypoxemia. Always asking the patient which nostril is easier to breathe through. Using the correct size lubricant tube to minimize the trauma. In children, the size are same as for oral intubation. For adults, they require smaller tube nasally. Hard PVC tubes cause more nasal trauma than the soft ones. High volume cuffs are relatively traumatic. Nasal intubation should not be performed in the presence of the fractures of floor of anterior cranial fossa. Always anticipation of difficult airway. Use of smallest tube possibly. Carefully use of intubating starlight. Aggressive GI reflux treatment. Antibiotic treatment for infection. Management of acute laryngeal edema including nebulizer racemic epi, steroid, observing the patient for 4 to 6 hours. Minor injuries usually resolve spontaneously after extubation. Consultation of ENT is advised with prolonged intubation. Trachea rupture requires emergency thoracotomy to repair the injury. Risk factors of perioperative ocular injury include general anesthesia, lung procedures, head and neck procedures, and lateral positioning. The incidence of anesthesia-related eye injury is estimated 0.06%. Important eye complications include cornea abrasion and post-operative vision loss. Anesthesia-related eye injury is rare for ocular surgery. It may be related to perioperative coughing or severe post-operative vomiting with a sudden increased IOP. The most common ocular injury during non-ocular surgery is cornea abrasions. The incidence is about 1.51 cases per 1,000 non-ocular surgeries. The etiologies include direct trauma or chemical irritation, face mask, anesthesia provider's watch, bandage, and air replacement, so on. The diagnosis is to examine the eye with a fluorescein stain and blue light. An urgent ophthalmology consult may be needed Usually, the injury will resolve within 24 to 72 hours with the proper treatment. However, 16% of cornea abrasion reportedly resulted in permanent injury in one study. For the treatment, the small abrasion with a moderate pain, we can use a topical eye drop or ointment for every 3 hours. The large abrasion, in addition to using the eye drops we mentioned here, we can give topical analgesic and oral analgesics. Always try to prevention of the cornea abrasions. Manually close the eyes and tape them as soon as the patient lost consciousness after induction of general anesthetic. Check to make sure the eye is completely closed. Intermittent to check there's no eyeball compression. Maybe some eye ointment help. Cornea protectors have been used to decrease the incidence. The incidence of post-operative visual loss will depend on the type of surgery. 8.64 cases per 10,000 cardiac cases, 3.09 cases per 10,000 spinal fusion cases. Other general cases, like 0.12 cases per 10,000 surgeries. The age range is like 5 to 81 years. Male patients more than female patients. Posterior ischemia optical neuropathy is an unknown etiology, but presumably a vascular injury by arterial hypoperfusion or possibly elevated venous pressure due to prone position and or interstitial tissue edema. It occurs most commonly in prone spine surgery of long duration and large blood loss. It also can occur in cardiac surgery, head and neck surgery, but rarely in other types of surgery. Other associated factors can be hypotension, anemia, excessive fluid administration, vasopressors, and elevated venous pressure. Anterior ischemic optical neuropathy is an unknown etiology, but like a PION, it is presumably a vascular injury by arterial hypoperfusion or possibly elevated venous pressure. It occurs frequently after cardiac surgery, but can also occur in prone spine surgery and head neck surgery. The next one is a central retinal artery occlusion. Emboli are usually the cause in cardiac surgery. Direct pressure on the globe in the prone surgery. The last one is cortical blindness, ischemia and infarction involving the occipital lobe of the brain, either due to emboli that occur secondary to manipulation of the large vessels during cardiac or vascular surgery, or from hypoperfusion secondary to hypotension. In terms of prevention of post-operative vision loss, PION or AION, since the etiology is uncertain, preventive measures are speculative. Resuscitation in large blood loss cases, head positional level with or higher than the heart, neutral head position, and considering stage-long spinal procedures. For the CRAO, proper positioning of the head with frequently checking the eye, make efforts to reduce the incidence of emboli during cardiac surgery. Although a minority of the patients recover some partial vision, the clinical improvement is insignificant and no proven options. In terms of treatment, for PION and AION, optimizing hemoglobin level, hemodynamic status, and oxygenation. Agents that lower intraocular pressure have been used unsuccessfully. For the CIO, optimize hemoglobin level, hemodynamic status, and oxygenation. Cortical blindness, we are going to increase oxygen delivered to the tissue oxytex by optimize cerebral perfusion pressure and hemoglobin. Arterial and venous thrombosis normally come from inherited hypercoagulable status, malignancy, pregnancy, and the embolization of the patient. For surgeries, orthopedic surgeries with the most thrombogenic procedures, 45 to 70% after total knee replacement in the absence of prophylaxis. Indwelling vascular catheters can be the problem, which is common with the central venous catheters and catheter sepsis. Further management and treatment. Start sub-Q heparin, graduate compressed stockings, warfarin for preventing PE. If the PE occur, treatment of PE is including primary treatment, thrombolysis, catheter embolectomy, clot fragmentation, or surgical embolectomy. The second treatment, including systemic anticoagulation and IVC filters. Intraarterial injection is rare. The incidence is 1 per 3,440 to 1 in 5,600 cases. The complications come from none to severe tissue ischemia, necrosis. The risk factors, including the patients who are unable to report pain, pre-existing vascular problems of forearm, high risk location where the arteries and the veins lines in close to each other, multiple infusions through several IV lines with numerous ports. Not all medications cause ischemia by the same mechanism. Some may cause crystallization and mechanical blockade of the blood flow. Others may be directly toxic to the endothelium. Regardless of the mechanism involved, thrombosis seems to be the common endpoint. In terms of treatment, we need immediately stop administration of the offending agent. Try to reverse or stop the arteriospasm, maintain or establish blood flow to distal extremities, treating any problems of vascular injury or ischemia. By the recommendation, the systematic relief, including maintain the catheter inside, identify potential for injury, initiate anticoagulation like heparin, give oral analgesics. There are some special intervention need to be concerned if the injury occur. Central lines and pulmonary arterial catheters could cause a problem. More than 5 million catheters were inserted per year in U.S. About more than 15% of these cases have complications. The complications are pneumothorax, vascular injury, infection, thrombus, venous air embolus, cardiac tamponade, hemorrhage, hematoma, arrhythmias, loss of guide wire, and vascular or cardiac perforation. The incidence of air embolism from catheter insertion can occur. The incidence is about 0.03% from insertion and removal of central line catheter with optional positioning technique. The morbidity and the motility is about proportional to the volume and the rate of the air entry, patient position, and the underlying cardiac disease. The patient may show shortness of breath, desaturation, and hypotension. The management including supplement with oxygen, 100%, and the cardiac support as indicated. Always put the patient on the head-down position, avoidance of deep inspiration. The incidence of pulmonary artery perforation or rupture range between 0.064% to 0.2%, with a mortality at 41% to 70%. The risk factors include advanced age, pulmonary hypertension, distal PAC migration, anticoagulation, hypothermia, and the PAC balloon overinflation. Try to withdraw the PAC catheter 2 to 3 centimeters once the weight tracing is obtained. Insertion depths of 40 to 45 cm depending on the patient and the insertion site. The management for this incidence may require one of the following therapy: lung isolation with a double lumen tube or endobronchial blocker, temporary unilateral occlusion of a PA, direct repair of the lacerated artery, lung resection, or embolization of a pseudoaneurysm. The incidence of a tourniquet-related injury is about 0.15% to 0.6%. Thigh tourniquet is less likely to cause a neurological injury than arm tourniquet. The risk is increased with cuff and forearm tourniquet. Permanent tourniquet reduced neurological deficit are uncommon. The majority of nerve injury resolve within 6 weeks, with complete recovery by 6 months. Maybe there are local injury, such as skin, muscle, nerve, and vasculature injury. There are systemic effects, including autotransfusion, hypertension, hypotension, hypercarbic, metabolic acidosis, core temperature change, deep venous thrombosis, pulmonary or systemic thromboembolism. The risk factors including tourniquet-related, which could be not regularly serviced and inspected for pressure accuracy device, bilateral tourniquet use and longer tourniquet times, vascular and metabolic problems such as diabetic peripheral disease and obesity, Raynaud's disease, and prosthetic vascular grafts. The patient may have a coagulopathy and other peripheral vascular neuropathy, prolonged embolization, and localized infection. In terms of management, the neurologist consult for nerve injury should be done. Pressure-related skin injury are treated as needed. Post-tourniquet syndrome is managed with elevation of extremities, monitoring the wound healing, and physical therapy. Arterial insufficiency of extremity requires surgical revascularization or thrombolytic therapy. Always carefully select patients preoperatively. Use wide, low-pressure tourniquet cuff. Inflate the tourniquet to the lowest pressure needed to prevent bleeding. Limit the tourniquet time to 2 hours or less. Set maximal tourniquet pressure setting as follows. Arm tourniquet normally 50 to 75 above the baseline systolic pressure. leg tourniquet should be 75 to 100 above the baseline systolic pressure. Ensure adequate padding beneath the tourniquet. Intraneuron injections is a rare complication. Intraneuron injections now is very impossible because we can visualize a difference between perineuron, intraneuron, and the intravascular injection with the ultrasound guidance. Multifactor nature of a neurological injury, the nerve anatomy, site of needle insertion, bevel type, location of the needle pressure, achieved during injection underlying factors. Peripheral neuropathy may be due to direct trauma or due to ischemia of intraneuron capillaries. Compression of peripheral nerves of stretching beyond 50% of original length could be the problem. The patient risk factors including diabetic, hypertension, and uremia, prolonged intraoperative hypotension and anemia. Ulnar nerve and the brachial complex are the most commonly injured during spine surgery. For ulnar nerve and the brachial plexus injury, the risk factors are male, with thin or very obese patients, prolonged hospitalization, the use of shoulder braces, the prone head down position, and some regional anesthetic techniques. SIZP monitoring, avoidance of abduction of the shoulder beyond 90 degrees, avoidance of excessive flexing of the elbow, avoidance of excessive extension of elbow, and always proper padding the extremities. Management of the peripheral neuropathies including neurology consultation, nerve conduct studies. For neuroapraxia, the injury is short-lasting. When we put a patient in the OR, we always need to check the position. Always make sure the arm abduction is limited to 90 degrees in supine patients. The arm position should be less pressure on the postcondylar groove of the humerus. The arm board needs to be padded. Always pad at the elbow and at the fibular head. Tissue burn is a primary complication in the OR. The device designed for prevention and treatment of hypothermia, circulating water blankets, hot pads, forced air warming blankets, and radiant heaters are potential problems. Device malfunction include we need to prop routine maintenance. If they are not, or they are not used according to manufacturer direction, they could be problem. The patient factors, including poor tissue perfusion, patients undergoing vascular surgeries, cardiopulmonary bypass, patients at extremes of age, and diabetic patients. Management for burn need to refer to the specialist. The best management is prevention. Do not use the forced air warming blanket in the area affected by peripheral vascular disease or other causes of impaired circulation. Avoidance of use of forced air warming blankets in any other way than indicated. Always operating warming device according to the manufacturer's instruction. Part B is chronic environment exposure. Teratogenic effects of anesthetics may not have conclusively shown in humans. Benzodiazepines were associated with a cleft lip problem, but further studies failed to show any relationship Recent animal studies show that fetal or newborn exposed to NMDA receptor blockers and GABA receptors, enhancers, IV induction agent, volatile anesthetic agent, resulting in neurodegeneration and persistent memory and learning impairment. Isoflurane has been associated with a post-operative cognitive deficiency in human adults. Part C is about the temperature. Hypothermia is referred to subnormal core temperature and divided into 3 types: mild, medium, severe. Hypothermia will increase blood loss by 16% and transfusion risk by 22%. Myocardial ischemia, arrhythmia, surgical wound infection, prolonged recovery from anesthesia have been reported. The risk factors of hypothermia include the body morphology. The risk is inversely to the body fat percentage. Age extremes, infants and young children, geriatric patients, size of incision, severe trauma and burns, chronic illness. Heat loss resulting from radiation, convection, conduction, evaporation. Radiation is to transfer of heat from one surface to another by emission photons. About 90% of heat loss in the operating room from this. Convection is to carry of heat from the core to peripheral. It is the second largest contributor to heat loss. Conduction is tissue transfer. It's a slow process. Evaporation is derived from heat of vaporization of water from respiratory evaporative losses, surgical incision, and skin prep. Oral measurements are adequate, but it is like 0.2 to 0.3 below core temperature. Core temperature can get from pulmonary artery measurement, nasopharyngeal measurement, bladder and esophageal measurement. Rectal temperature is acceptable in pediatric patients. In terms of prevention and treatment of hypothermia, is by limiting skin exposure, active warming with a forced air warm device, warming IV fluids and irrigation fluids, and operating room temperature above 21 degrees. Post-operative shearing can occur up to 40% of the patient after general anesthetic, up to 30% after epidural anesthesia. It is increased O2 consumption by up to 300%. The most commonly occurs as a complication of hypothermia. Normothermic shearing can occur in younger patients, prolonged surgery, and orthopedic surgery. The preoptic region of hypothalamus is a dominant autonomic thermoregulatory center. Shearing serves as a normal physiological protective mechanism to create warmth by energy expenditure. Intraoperative temperature monitor. The core body temperature is our standard care. Always use a blanket and drips to decrease radiation. First, air warm devices are the most effective way to warm the patient up. Other methods including heated, humidified anesthesia circuits, adjusted ambient temperature in the operating room, warm IV fluid, and blood products. For the treatment, hypothermic shivering can be used by warming the blankets or forced air device. Non-thermoregulatory and hypothermic shivering can be treated by medications. The most effective medication is meperidine, 12.5 mg for 25 mg IV. There are other medications are reported they are effective for treating this problem. Hyperthermia is defined as the elevation of the core temperature above normal range and is due to a failure of thermal regulation. The instances include neuroleptic malignant syndrome in patients taking neuroleptic drugs, range from 0.02 to 3%. Unexplained postoperative fever is common and will be resolved within 48 hours without antibiotic treatment. Passive hyperthermia could happen. The patient was too warm from excessive heating conducting warming system, fluid and blood warmers, and warm operating rooms. It could come from drug reactions. The fever may come from UTI, abscess, cancer-related infections, sepsis, meningitis, pneumonia, atelectasis, and wound infections. Could be other reasons like endocrine problems, hyperthyroidism, thyroid storm. Could be from monitor error, connective tissue disease, hematoma, transfusion reactions, and the infusion of contaminated blood products. Monitoring temperature intraoperative to avoid anaphylactic hyperthermia. Always use a sterile technique for the line placement and treating infection with antibiotics, avoiding ventilator-associated pneumonia, DVT, and PE. In terms of complication of hypothermia, it can increase metabolic rates with increased O2 consumption, acidosis, and myocardial ischemia. It can worsen neurological injury following ischemic events or seizure, which will increase cerebral blood flow, releasing excitatory neuron transmitters, resulting in seizure activity in children and permanent CNS damage with temperature above 42. It can cause rightward shift of the oxygen hemoglobin dissociation curve. Management of hypothermia should be directly at the underlying causes. Active patient cooling when the temperature is beyond 39 degrees. Lowering the room temperature, removing drapes or covers, turning off a warming device, blowing cool air over the patient. For the severe cases, apply ice to the groin, axilla, or neck using cooling IV solutions. Ice water lavage can be used into the surgical wound. For the severe cases, cardiopulmonary bypass could be the choice. Part B is about bronchospasm. Bronchospasm is caused by spasmodic contraction of bronchial smooth muscle. Triggers in pediatric patients including environmental allergens and viral respiratory illness. Triggers in adult patients including mechanical chemical irritants and viral illness can cause normal patients to increase airway pressure. Other risk factors including recent viral upper respiratory infection, exacerbation of pulmonary symptoms, recent hospitalization for treatment of asthma, and exposure to tobacco smoke. The causes of acute bronchospasm in perioperative duration may from nonspecific bronchial hypersensitivity, allergic or anaphylactic reaction to drugs or blood transfusion, allergic or anaphylactic reaction to other allergens, exacerbation of asthma. Some medical agents could be a reason, stimulation of parasympathetic fibers, and tracheal irritation from intubation. High-risk patients should receive steroid and have baseline PFT. Pre-treatment with a nebulizer, beta agonist, IV nebulized or intratracheal lidocaine can help. Use propofol induction instead of pentothal or etomidate. All potent inhaler agents effectively reduce airway resistance. Regional anesthetic is the choice. Always provide adequate depth of anesthesia before and during airway manipulation and tracheal intubation. When bronchospasm happens, we need to deep anesthesia with potent inhalation anesthetics or IV anesthetics. Administer beta agonist bronchodilators. The drug of choice is epinephrine. Adult dose is 0.1 to 0.5 ml of 1.1% epi. Pediatric dose is 0.01 ml per kilo of 0.1% epi. Other drugs can be treated if the situation is severe. Part E is about anaphylaxis. Anaphylaxis is a life-threatening reaction to foreign substances. Previous exposure to the inciting agent are needed. It is mediated through IgE. It can cause cross-reactivity among commercial products and drugs. On the other hand, anaphylactoid reaction is clinically indistinguishable from anaphylaxis. It is not required prior exposure to the allergens. It is a direct non-immune mediated release of mediators or direct complement activation. There are 4 types of immune-mediated allergic reactions. Type 1, or immediate hypersensitivity, is IgE-mediated hypersensitivity, and the most severe form results anaphylaxis. Type 2 reaction involves IgG, IgM, and the complement cascade to mediate cytotoxicity. Number 3 reactions are the result of immune complex formation. Number 4 reaction or delayed hypersensitivity are mediated by T lymphocytes, such as contact dermatitis. There are common causes of anaphylaxis in the operating room, according to all the studies. Muscle relaxants were listed as number 1 substances. One study showed 69% of the muscle relaxant cause anaphylaxis, followed by neuroleptics, antibiotics, hypnotics, colloids, opioids, and other substances. The incidence of latex allergy in general population is about 1 to 2%. Healthcare workers is about 3 to 14%. Rubber industry workers about 10%. And spina bifida and congenital urogenital problems is pretty high, 24 to 60%. In general, the populations at a high risk for latex allergy include healthcare workers, children with spina bifida, multiple surgical procedures, atopic patients, frequent or prolonged wearing gloves, workers in the industrial, fruit allergy, female agenda. Raw latex is a milk from the rubber tree to which ammonia is added as a main preservative. There are 3 types of allergy to latex. Number 1 is irritant contact dermatitis. It's a non-immune reaction. Number 2 is chemical sensitivity dermatitis. It is a delayed hypersensitivity reaction from the type 4 reaction. Number 3, the latex allergy is immediate hypersensitivity type 1 reaction. Every institution always have latex safe precautions. Always identify the patient and the caregivers at a risk sensitivity. Creating treatment protocols for patients with a latex allergy. Identify the latex content of products. Education of the hospital and the medical staff members. In terms of management of anaphylaxis, always call for help. Immediately stop administration of antigen. Maintain air with 100% O2. Try to limit the use anesthetic agents as much as possible. Aggressively to give volume. Epinephrine is the first choice. 5 to 10 mic initial bolus, titrated as needed. Other drugs include antihistamines and Hy blocker and H2 blocker. Steroid can be used. Nebulizer albuterol for bronchospasm. Vasopressin can be added to the treatment. If the case is severe, catecholamine infusion might be needed. Part F is a laryngeal spasm. Laryngeal spasm is a protective relaxed closure of the glottis as a result of abnormal stimulus. The incidence is over 0.87%, 1.7% in children, and 2.82% in infants. It causes oxygen desaturation, brain injury, negative pulmonary edema, bradycardia, pulmonary aspiration, and cardiac arrest. Laryngeal spasm is mediated by skeletal muscle, while the bronchospasm is a small muscle mediated. Etiology including insufficient depth of anesthesia, younger age, airway irritation, airway manipulation, upper respiratory tract infection, smokers, and passive smoke exposure. Treatment of laryngeal spasm is according to partial laryngeal spasm or complete laryngeal spasm. With a partial laryngeal spasm, CPAP with 100% O2 and a tight-fitting mask or increase the depth of the level of anesthesia. For the complete laryngeal spasm, we are going to start with CPAP 100% O2, jaw thrust, and chin left. Increase the anesthesia level with sevoflurane. If this does not work, we should continue treat with sucks and IV propofol and give atropine with sucks for children, and even gentle chest compression with 100 O2 in children. Prevention of laryngeal spasm can be done by topical lidocaine, mask induction with sevoflurane, not desflurane. Always give adequate dose of muscle relaxant to minimize the chance of laryngeal spasm. Carefully suctioning of the oral pharynx before emergence from anesthesia. Medications to reduce secretions and avoid painful stimulation during emergence. Part G is about postoperative pulmonary edema. That is the result from negative intrathoracic pressure generating during a spontaneous ventilation occurred upper airway obstruction. The incidence of anesthetic practice is about 0.05 to 0.1%. The pulmonary edema results from pooling of fluid from pulmonary capillary bed into the alveoli, or injury to the pulmonary microvascular membranes from severe mechanical stress that result in capillary leak of fluid. Etiology including laryngeal spasm, the tube biting, airway trauma, foreign body aspiration, bronchial obstruction, and upper airway collapse. Some surgical procedures are high risk, oropharyngeal surgery, tumor, or obstructing masses. Prevention is always important. Try give the bite block to the patient to prevent biting on the ET tube. Prophylactic placement of oral nasal airway. Treat laryngeal spasm aggressively. Treatment of postoperative pulmonary edema, we can start a trial of CPAP. Reintubation and ventilation only reserved for severe cases. Bronchodilators, diuretics are used. All benign conditions can be resolved in 24 to 48 hours. The part H is about aspiration of gastric content. Inhalation of gastric, oropharyngeal, or other foreign contents to the larynx or low respiratory tract causes problem. Aspiration pneumonitis is inhalation of sterile acidic gastric contents, resulting chemical injury to the lungs, also known as Mendelssohn syndrome. Aspiration pneumonia is an infectious process caused by inhalation of secretion that have been colonized by microorganisms. The incidence is around 3.1 to 10.2 per every 10,000 patients receiving general anesthetic. Large particles could cause airway obstruction, ventilation perfusion mismatch, shunting, hypoxemia, and death. Aspiration pneumonitis is an acid-related effect of gastric contents. Could cause inflammatory reactions, direct lung tissue injury, airway constriction, and edema. Aspiration pneumonia is from the oropharyngeal secretions and contaminates gastric contents with bacteria, which could cause acute inflammatory problems. And normally, the bacteria could be gram-positive Coxiella, gram-negative rats, and rarely other types. Prevention of aspiration is important. Always make sure the patient has adequate preoperative NPO time. Use medications to decrease gastric acidity, decrease gastric volume, and application of cricoroid pressure is questionable. Early intubation with a cuff tube. When aspiration occurs, treatment including vomiting at induction should be put the patient on the Trendelenburg position, suction the upper airway, endotracheal intubation, and inflate the cuff. Then endotracheal suction and bronchoscopy to remove the large inhaled particles. If the vomiting is at the mask ventilation or subglottic device, should remove the device immediately. Maintain critical pressure. Patient head-down position or lateral position, suction the airway with 100% O2, endotracheal intubation, and expedite the surgery. If the vomiting and emergence, put the patient at head-down position or lateral position, gently suction of the upper airway with 100% O2 if reintubation needed. There's no data support use of steroid in the treatment of aspiration pneumonitis, and aspiration pneumonia.